first.
No, I don't. So, welcome everybody. My name is officially Jerome Engel Jr. known as Pete. I'm the director of the UCLA Seizure Disorders Center. And I'm about to sneeze. Hold on a second. So this is a session on difficult to treat epilepsy. How many of you are here for the first time? Me too. I'm overwhelmed by how many people are here and all the exhibits. And I'm not sure exactly what the protocol is for this. And I think it's anything you want it to be. So I can give you a little introduction. To begin with, I'm an adult epileptologist. I'm not a pediatric epileptologist. And I noticed that almost everything here has to do with children. So how many of you are here because your children have epilepsy? Well, the rest of you are adult epilepsy. Just to give you some figures, if you're not aware of them. The World Health Organization has determined that epilepsy accounts for 1% of the global burden of disease. The global burden of disease is calculated as the number of life years lost due to disability and premature death. 1% is equivalent to breast cancer in women and equivalent to lung cancer in men. Among primary disorders in the brain, it's equivalent to depression, to dementia, and to substance abuse. And I'm sure you recognize that these other diseases get a lot of attention in the press, and epilepsy gets none. And the amount of resources that governments give to epilepsy depends on the attention it gets by the media and the actions of the people who have it. So we're really, as people with epilepsy and epileptologists, not getting our fair share of what we need. And the reason for this are not clear. A lot of it has to do with the fact that epilepsy has been stigmatized since biblical times. In the Bible, there were 3 stigmatized diseases. Besides epilepsy, there was cancer and leprosy. And cancer and leprosy have been destigmatized. But it seems that epilepsy is still stigmatized, and then famous people who have epilepsy don't come out and talk about it. You know, the way, what's his name, Michael J. Fox talks about Parkinson's disease, or Jerry Lewis used to do things for most people. There are no spokespeople like that for epilepsy. And it's wonderful to see all the activity here, and it's up to us to change that. The other thing is that there are over 3 million people in the United States who have epilepsy. And about a third of them have seizures that are not controlled. That means that there are probably over 1 million people in the United States who have seizures that are not controlled by medication. And less than 1% of them are referred to specialized epilepsy centers. Are you all aware of specialized epilepsy centers? Yes? No? How many of you have been seen at a specialized epilepsy center? So again, it's difficult to understand why that is. That many people who have epilepsy, whose seizures are continuing despite treatment, might be helped if they were seen by super specialists at epilepsy centers. They might be candidates for other kinds of procedures or for experimental drugs. Or maybe they don't have epilepsy at all. At our center, a third of the people who come to see us don't have epilepsy. they've been treated as having epilepsy for years, but they have something called psychogenic non-epileptic seizures, and they require a different kind of treatment. The data that I gave you from the World Health Organization, WHO, about 1% of the global burden of disease is really a serious underestimate, because when they did that analysis, if people had epilepsy because of some other disease, like they had a stroke or they had a brain tumor, then they were classified as a stroke or a brain tumor, and they weren't classified as epilepsy. So that the people in the world who are disabled by epilepsy are much greater than what we would assume from that 1% figure. So it's actually worse than breast cancer, and worse than brain cancer. And the same thing in the calculations that we do in this country and in other developed countries about the percentage of patients who have uncontrolled seizures. I said it's about a third. It's actually more than that, because maybe it's a third if you look at who has gone a year without seizures. But people who may be controlled this year may not be controlled next year. Seizures come and go. So this is a huge problem. It's a huge problem that's not being taken care of because patients and their doctors don't know what to do often and don't refer their patients to people who at least have something else to offer. So there are many reasons why seizures may not be controlled. Maybe because you're on the wrong drug, or you're taking the wrong dose, or because you have been diagnosed as having the wrong kind of seizures, or you don't have seizures at all. Or maybe because you have lifestyle issues that cause you to have seizures. Maybe you have a job where you don't sleep enough, and that causes seizures. Or you're abusing substances that cause seizures. There are many reasons why people continue to have seizures. They can be fixed. And I don't think that word gets out well enough to doctors as well as to patients. So this is supposed to be ask the experts. I think I've talked long enough. We need to hear what you want, what your questions are. Questions? No, this is not a lecture. This is a question and answers.
She's gone through surgery. She has an issue with the medication. She gets medication for the rest of the wall for 2 weeks, and then it's and she was talking to me, and she said, well, just get up and walk.
So she's better, but she's still
better.
seizure.
But for 2-3 months after the surgery, she was actually walking without and seizures were being stopped. And being playing in the medicine, I don't know. Sometimes I feel the medication is causing the seizure, because when she gets any knees on the dose, she gets any knees on the seizure. So then I have to go down because.
How long ago did she have the surgery?
A year ago.
And when did the seizures come back?
They came 2 months, 2-3 months after.
And were they the same or different?
Different ones. She gets like 8 different kinds of seizures.
But are the seizures that she gets now the same as the ones she had before?
No.
They're different.
They're different. She used to have up to 200 seizures a day. She went down to 6 to 12, 15 when it was a bad day. But they're different now. And she gets different kinds of seizures.
Has she been evaluated again at the center where she had the surgery?
We just did an MRI because we're getting ready to see what else we're going to do. Or what we're going to do, but I'm still trying to find other options before we go in and do the next
But what, can I ask you where?
with Dr. Millett and the,
Yeah. So he's very good.
he's very good. He did all the tests that he could have done. He did the generics, he even got the med test that's on the that was the last one we did to see where the problem is. It shows different, it's a network, different spots.
Now, we're learning a lot about the networks now. This is fairly new.
Yes.
And how they interfere with the network. And everything take the way out.
Yes. So they went into the big one, the big part where they're not the most of the problem. And it got better.
Yeah, well, I think Dr. Blood knows what he's doing, and that's the right thing to do, is to do a complete evaluation again.
Yes.
To try and figure out where these are coming from. Because it doesn't sound like drugs are going to fix this.
No, no. And we've been going through we've done a lot of testing. And I know, and by talking to other people, what they've done, they've been told, I know we are in the right, we're going in the right direction. And it's still like to figure out the function, what we were talking about the center. If that would be something that we go, I don't know.
Well, it is a center. What he has is a center.
It's a center, right?
Yeah, no. And he trained with us, so I know that he's good.
Oh, well, we actually went to the UCLA for one of the tests.
Uh-huh.
And I think one of the doctors from there was also involved
Yeah.
with him.
Yeah, well, he's affiliated now with USC. He was trained by us, and he does things the way we do, and I doubt that there's much different that he's doing that we wouldn't do. So that the approach when the seizures come back is to reevaluate completely, which means an EMU station. I assume she's been in recording again procedures in the hospital.
Yes. So that's where
And then MEG is great.
he is they've done an awesome
No,
job.
I mean the Meg.
Yeah. Oh, the mag test is, yes, because we did the, yes, yes. We did that. We went to, that was the last one after the generics, all the MRI.
So he's probably thinking of what we call response neurostimulation.
Yes, so
Instead of
the
surgery.
little computer,
Right.
yeah.
And that's a new concept. That's a very, everybody knows about it. No? It's a computer that gets embedded in the skull with electrodes that go into the areas where the seizures begin and record the seizures. And when the seizure starts, it triggers a computer that sends a stimulation that stops the seizure. So when it starts in the EEG, it starts before the behavior seizure. And that can be very helpful to avoid the seizure most of the time. It doesn't really get helps.
No, it doesn't work 100%, but now we have, the surgery worked, he's at 80%.
Yeah.
80-90%. Help. But now that small percentage, maybe
Right.
the computer may take care of that, so that's what we are.
But this has been a really wonderful thing for us, because when we have patients that come who are candidates for surgery, and we do the evaluation, and we find they're not candidates for various reasons, it's very depressing for us as well as for them. Now we have something to offer. And the same thing, if we do the surgery and the surgery doesn't work, it's very depressing for us as well as them. So this is something entirely different. That even though it's called palliative rather than curative, which means that it doesn't cure the seizures, but it makes them much better. And it's definitely. You have a question?
So I'm going to sort of community epilepsy, but my neurologist said he believes it's a grand neurology seizure that I have. And my last seizure was in April. And I feel like he's not giving me the correct diagnosis, or he's just like saying whatever it is, it doesn't want to be out of treatment or whatever.
How many seizures have you had?
But they're all within 6 months or 3, yeah, like 5 to 6 months. So I don't know if I should seek for an epileptologist or pediatrician. Should I go for? Because I don't want to be waiting and then
Yeah, if you're continuing to have seizures, you've been on only one drug,
yeah,
he hasn't changed the drug.
he's increased the dosage.
What we consider drug refractory epilepsy, medically refractory epilepsy, and drug resistant epilepsy, names seizures that don't respond to drugs, is failure of 2 drugs. And the 2 drugs can be taken separately or together. So if you've just begun having seizures and you're trying on one drug and that drug doesn't work, and another drug is added, and that drug doesn't work, then your chances of being seizure-free as a result of a 3rd drug is only about 3%. So officially that's considered drug-resistant epilepsy. And when patients have failed 2 drugs, the recommendation is that they go to an epilepsy center where they have other ways of determining what's going on and other treatments. And as I said, the problem is that less than 1% of patients are actually referred to epilepsy centers at that point, and we don't post them. But if doctors don't refer them, it has to come from the patient. But we've only been trying to one drug. So you have a warning.
Yeah.
And you're having a warning.
I did. And he just said, oh, well, just try to sleep, get more rest, and not be stressed out or something. He thinks that my seizures are due to stress.
Well, it's true that stress and lack of sleep can cause you to have seizures. But that's not necessarily the answer. When you don't want to be a zombie because you're afraid you're going to have a seizure, and you can't always get a good night's sleep. And if you're going to live a normal life, you're going to have stress. So you want to be on a medication that controls them when you're under stress, or something else that works. You can always refer yourself to an epilepsy center to another doctor. And if you don't think your doctor is taking this seriously, you can see another doctor. I would, I don't know whether it's that appropriate for me to say this, but I know that there are many different kinds of doctors. And you have a right, if you don't like the doctor you're seeing, to go see another doctor, unless you're in some sort of a health system where they tell you you have to see this doctor. There is, and even in the health system, you can go see another doctor in the health system. So, doctors are like anybody else. They're doctors that work well with some patients and not well with other patients. And this doctor may not particularly like him, but other patients may think he's terrific. So you can't satisfy everybody all the time. But if you don't like your doctor, or you don't think your doctor is doing what you need, you have a right to go see another doctor. Or to go to a center and ask him to refer you to a center. And if he will refer you to a center, that's something.
So I'm from Epilepsy Support Network, and we get calls from people
who want to go to an epilepsy center, but they're in Kaiser, which is not an epilepsy center.
Kaiser has epilepsy centers.
They do, inside, so Orange County, I don't know, I've been told that Orange County has 3 main epilepsy centers, epileptologists, and it's outside of Kaiser.
Well, Kaiser has an epilepsy center in Los Angeles.
In LA.
I don't know if they
Not in
have
Orange
one in
County.
Orange County. I
Yeah.
think the Sunset Kaiser is an epilepsy center.
Yes, it
I
is.
see.
Sunset, Kaiser Sunset.
That's that level 3 and 4 epilepsy center for Kaiser is
Yeah.
in
And, well,
Los Angeles.
For a while, they didn't have a surgeon, and Kaiser was sending their surgical patients to Irvine, and Jack Lynn was doing the surgery, and we were very jealous because he was doing a lot more surgery than we were.
Okay.
But now Kaiser has a surgeon,
Okay.
and they're doing their own surgery.
So people that live in Orange County, we can tell them that they don't have to go outside of Kaiser to
Right,
go
I
to
mean,
the epilepsy center.
I don't think it makes any difference where you are. If you're in the Kaiser system, you can go to any Kaiser hospital. So they can go to the Kaiser center.
Because I was always like, I didn't, it costs more money for people to step out of Kaiser and go to Hope because that's HMO.
I have Kaiser insurance and you can switch
Yeah, you can
from
switch.
wherever the specialty that you need is at, they'll send you to, because it is all Kaiser. Although they do separate it, Kaiser of Orange and
Yeah.
LA Kaisers and that, but they do
But they can
cross
drive.
over.
But there are some things that Kaiser doesn't do. So we do get patients who come to us from Kaiser,
Yeah.
where Kaiser pays for it because Kaiser doesn't provide that service. So they pay for them to come see us.
I see.
So, but I think this patient doesn't know at this point what they need, but they do need to go to a center, and they can go to the Sunset Center,
Yeah.
and if they can't help them, then they'll send them somewhere else and they'll pay for it.
Yeah.
Ask a question. What do you, because we just go to a doctor and we're not from here, but what do you get from an epilepsy center? What do they offer?
Okay, an epilepsy center, if it's a full-service epilepsy center, can make diagnoses that are missed in the community, and can determine the causes of your epilepsy. So if you're having seizures, the most important thing is to understand why you're having seizures. And the seizures may be due to a treatable cause. It's treatable apart from just the anti-seizure medication. And sometimes that's missed in the community and requires a special testing that they do at epilepsy centers. So that's one thing, is that they can provide diagnostic services that are not available in the community. And what they find out sometimes is in patients who have been treated, as I said before, as having intractable epilepsy, turn out not to have epilepsy at all, to have something else. And they've been totally mistreated for years. So that's one thing they can do. Then they can come up with alternative treatments. So alternative treatments may be just changing your medication around because of a better diagnosis. Surgical treatment is one of the major things that the full-service centers do. Not everybody is a candidate for surgery, but there are many different kinds of invasive procedures now. So the most benign is vagus nerve stimulation. That's offered a lot of times in the community. But it's also done inappropriately in the community because many patients who might become seizure-free with surgery are treated in the community with VNS. That's not adequate. So you need, before before you get VNS, you need to make sure you're not a candidate for a much more definitive surgical procedure. So now, in addition to the routine types of surgical procedures that we've been doing for years, which either involves removal of the area of the seizures or some kind of disconnection, you can now do laser ablation, which is semi-invasive, and in some cases is just as effective with less side effects. We can also do responsive neurostimulation, which we were talking about before, which is a computer that detects the onset of seizure, stimulates and reports it. That's a real discrete image. Neuroscience now, it's working, and it's wonderful because when we evaluate patients for surgery and they're not surgical candidates, very often they are candidates for diabetes. And then there's something called deep brain stimulation, DBS, which also is palliative. It greatly reduces the frequency and severity of seizures, but doesn't usually stop them. Then there are other things like diet, like the ketogenic diet, that can be done. Other experimental drugs that can be done. And an important thing that's offered at full-service epilepsy centers is psychological and social support systems. So in the patients who continue to have seizures where no treatment is really available that can stop the seizures completely, these are services that help patients deal with their seizures. Social issues and many patients who have seizures have not only social problems as a result of that, but psychological problems as well. And there are special treatments for that. And epilepsy centers are specialists in that sort of thing. So even if your seizures can't be stopped, there are other things that can be done.
We've been through some of that because, well, she was sixth in the nation to have a VNS.
She was what?
Sixth in the nation after they approved it to
For
have a VNS.
Did it
But
help?
it did. It cut her seizures in about half. But we did have the telemetry done, and her EEG looked like the seismograph. She seizes continuous. And I don't know if there's ever going to be anything. They said her seizures come from throughout her whole brain. And she's on 2 meds, but she's had them for over 30-some years. And I mean,
Has she been back to a center lately? Because DBS may be the appropriate treatment now.
Well, would that work though if they're throughout her whole brain?
Yes, that's what DBS is for. DBS is for the kinds of seizures where there's no focality, there's no localized area that can detect where the seizures begin. Because if we can detect where the seizures begin, we can remove it.
Right.
Unless it's an area that can't be removed, and then we can do responsive neurostimulation. But if we can't figure out where it's coming from, then we do DBS, which is like VNS, but it's better. But we also have much better diagnostic techniques, so that MRI scans are much better than they were when she had VNS. We have PET scans, and PET MRI fusion allows us to find small little abnormalities in the brain that you can't see on the MRI alone. But when you see it on the PET and you put the two together, suddenly you can see the abnormality in the brain. There are a number of other tests that are being done. There are functional MRI studies that are helping to understand the connections in the brain that can be abnormal in epilepsy. So our diagnostic capabilities are great. And then, of course, magnetoencephalography, which is represented by MEG, is a non-invasive way to look at the whole brain to find the epileptic abnormalities. And that's been extremely useful to localize things that couldn't be localized in the imaging.
Yes, she could. Years ago, when she was younger, and had some.
Yeah.
And that's where they pinpointed some of the names I got from, but it's just, they said that she would never be a candidate for surgery.
Yeah, that was probably in San Diego, probably
Believe it or not, it was in Mexico.
in New Mexico. Because that's changed a lot lately. And there's also something called SPECT, single photon emission computed tomography, where you can inject a patient during seizure, and it will light up the part of the brain where the seizure comes from. And that's another test that can be done. So I would bet there's a lot new since the last time she was evaluated.
So
And it's worth
how
doing
do we
again.
find an epilepsy center? I mean, where would we go to find?
Where do you live?
We live in New Mexico.
In New Mexico. Well, the University of New Mexico in Albuquerque is an epilepsy center.
Yeah, but they're about 10 years behind. They really are. They're really behind.
Well, you can contact the Epilepsy Foundation, which will give you a list of epilepsy centers, and you can take your pick. There's also something called the National Association of Epilepsy Centers, NAEC. There are about 140 epilepsy centers in the United States, but they're not all full service. And there's some epilepsy centers that only do 1 or 2 surgeries a year. I think, my bias is that if you're going to have surgery, you want to go someplace that does a lot of it.
Is there a way that even though she's seizing continuously, that they can stop that? I mean, like you said, it may be with that.
Well, it depends on the cause. So the first thing that she needs is a reevaluation to see whether these new techniques can determine what the cause of these are. We're also learning about metabolic causes, and autoimmune causes, and infectious causes, and other things that can cause seizures that we can detect now that we couldn't 10 years ago. But the field changes rapidly, so don't give up.
I have my daughter was epilepsy, and in 2006, we went to Mayo Clinic in Rochester, Minnesota. We just spoke about the SPECT, and then she has gone through all that has SPECT. After the doctor's conference, they revealed that my daughter's epilepsy. This year, however, we were sent to an MEG center to prescribe, and our doctor said now they can do the surgery. So is that technology advancement from that time on?
Yes, yeah. SPECT has very limited value. MEG is much more accurate, but MEG in itself is not enough. So if the MEG shows that the seizures are coming from a particular part of the brain, they would need to do some other tests to confirm that before they do the surgery. But that's good news for them.
So, just more about like the process of like switching medications. Because I know, like my neurologist person said like the switch is going to be hard, but I don't know like what that means, or like what the process would be like of switching, like from
drug that you're on now isn't working?
It was working for a while, and then I had another seizure, and then we brought it up, and then I had another seizure, so like, they're saying it's not really working anymore. So I don't know if they would add another medication on top of that, or just, like drop that, or like rapidly drop it and switch, or how would that?
Yeah, then the disease you have, juvenile myoclonic epilepsy, is usually easily treated. But the drug that treats it is best is difficult, which is not good for young women because it causes great problems. So we use other drugs that are not as good, and it's unfortunately still a matter of trial to find one that works. And the way that's done is that another drug will be added to the drug you're on now. And then if that drug works, your doctor may decide to keep you on both drugs or to slowly take away from the
Dr. Davis was great, said I just wanted these two, do some research on them, and decide which one you want. I just told me this yesterday. And we were just trying to, I have my notebook, but we love solutions so far. It's one of them was pretty more, one of them was basically one of the side effects is tingling in the feet and the hands and confusion. She's going to get that. And I'm sorry. And then the other was capital. So I don't know. She just turned 16, so I don't know. We went to one of the other things that were the doctors there, and we were going to go and they said continue. We were seeing reports from them to the
Yeah, I think in opinion is a reasonable thing to do, but you can go online and see what the side effects are of these different drugs. I guess he's telling you to do your own research and make up your own mind what you want. I mean, there's no hard and fast way. There are certain drugs that are good for this disease and many drugs that aren't. So there's not a big selection. So it's not an overwhelming job to look at them and see which one appeals to you, because you're the one that has to decide. But they're all pretty much the same effectiveness. They all have different side effects. So deciding which drug to use more often than not for any kind of epilepsy, more often than not, has more to do with the side effects than it has with the effectiveness of the drug. And different side effects, some people prefer one kind of side effect, other people prefer another.
You mentioned the diet earlier. You mentioned the diet
Ketogenic diet.
Yeah, the ketogenic diet is not, I think drugs are more effective for this. The ketogenic diet is more for the more severe epilepsies that don't respond to drugs. The ketogenic diet is very difficult to do. It's that, the modified ketogenic diet actually works. What is it, the famous one? Atkins diet. Yeah, and some people benefit from that. But you have the classic form of epilepsy where sleep deprivation and stress and alcohol make it worse.
No, we just, we're new to this. We just found out about this last night, actually. Some of our doctors popped up, but we're grateful that we were coming in, but I guess it's a lot of learning, and we don't know anyone in the house. And she just met some girl actually in her class that has a similar epilepsy.
One one of the most common forms of epilepsy in teenagers.
But one thing the doctor says you kind of keep it on an intimate basis. So the reaction I get from people when they mention is like, oh, it's contagious, like we don't know how to talk about it, and it gets kind of uncomfortable.
That's the big problem with epilepsy, is this stigmatization and all the misconceptions. And it's because people who have it don't talk about it. When I go to talk to medical students, for instance, and I ask how many people here have actually seen a seizure, a lot of the hands go. So how many people here have relatives who have a seizure? A lot of hands go. And so look around and see how common this disease is. And then I said, how many of you have actually had a seizure? No hands go. And I said, do you think if somebody here had a seizure, they would put their hand up? And then they'll come up to me after class and say, yeah, I have seizures. But they don't want to let to know. I have a friend in England who said that more money was raised in England the previous year for leprosy than for epilepsy. There hadn't been a case of leprosy in England in 10 years. So something needs to be done. There are a lot of advocacy organizations out there. They are trying to change what the public thinks of epilepsy, so people can come out of the shadows. It's worse in many developing countries. In Africa, it's thought to be contagious, and it's most contagious when somebody's having a seizure. So if somebody has a seizure and falls in the river or falls in the fire, nobody pulls it up because they don't want to get it. And it's known as the bird disease because you can tell somebody who has epilepsy because they're covered with burns because they fall. In India, if you have epilepsy, it's very difficult to get married. So it's the social, I talked about the social and the psychological issues that are addressed in epilepsy centers. The social and psychological issues are more disabling than seizures themselves. And if somebody has epilepsy and they have 3 or 4 seizures a week, that's a lot. And 3 or 4 seizures a week for 2 or 3 minutes a seizure is nothing compared to the problems they face every day because they have epilepsy. They don't want people to know it, or people don't think things about them. Or they can't do things because they don't know when they're going to have a seizure. And treatment is still trial and error with drug treatment. It hasn't changed for over 50 years. And what we really need is a biomarker. There's a lot of research trying to find biomarkers. You know about hemoglobin A1C? Is that familiar to you?
Diabetes?
Yeah. Hemoglobin A1C is a blood test for diabetes. And people who have diabetes or are diagnosed by the hemoglobin A1C, and then their treatment is determined by whether their hemoglobin A1C is on or down, and that's called a biomarker. It's a biological test that allows you to determine whether somebody has a disease and whether that disease is active or not. So if we had a biomarker for epilepsy, when somebody has a seizure, we don't treat them right away because we don't know whether this is what we call a reactive seizure. Because seizures are very common. Your chance of having at least one seizure if you live to be a normal age is 10%. 1 in 10 people will have at least one seizure. But only a third of them will have a second seizure and go on. So if somebody comes in with a single seizure, we don't know whether they have epilepsy or not. And so we don't usually treat them unless we can do tests and confirm they really have a problem in their head that we can find. So many people with epilepsy don't get treated until they have 2 or 3 seizures. And the second and third seizure could really injure them. And if we had a biomarker that we could say, you definitely have epilepsy, we could treat them right away. If we had a biomarker, we could say, okay, this drug is going to work. We could try a number of different drugs. You don't have to wait for them to have another seizure. If we had a biomarker, if somebody has a head injury, we can say, you're going to develop epilepsy from this, and we can prevent it. But we don't have a biomarker that can do that, so we have no way to prevent epilepsy when somebody has a potential injury. So biomarkers are on the horizon for making good inroads. And that will revolutionize the treatment, the diagnosis and treatment of epilepsy. So as I said, things are rapidly changing. So for you, we would want to have a biomarker that can tell us what drug is going to work for. But right now, they sit on the side effects. What?
I'm just saying that church center business
Anything else? How many of you have been to an epilepsy center? Just, well, you were. And there's no reason not to go to more than one if you're not getting what you want.
The more I hear about it from other people, everything that I hear from other people, we worry about. So then I feel like we're on the right place. So I talked to a lot of people that have been seen by people that are seeing their own doctor, just a neurologist, which is one of the mistakes that we made at the beginning, going to a neurologist. They were not going to do it.
Yeah. Well, that's what they should do is refer you to that.
Exactly.
But unfortunately, they don't.
And that was back in my country, it was not here. They just give medication and then say there's nothing that I can do for you. Don't come back.
One of the things that have been done is there are quality of life tests that can be given to show how seizures affect your quality of life. And it's no surprise that people with epilepsy have a quality of life that's less than people who don't have epilepsy. But they found out that when somebody goes to an epilepsy center and has all these tests done, even if they're not any better, their quality of life is better because at least they know they've done everything they can.
Our doctor did not give up. He started out with the EEG, then the PET scan, the MRI equipment, we got contrast, and then we did the generics, and then more MRI, and then we ended up with the leg test.
Yeah, well, once you get into an epilepsy center, they're not going to.
No. And then they did the mapping, and for me to know that she was going to have a brain surgery, and then Dr. Millett came into the hospital room to do the mapping. That kind of gave me a lot of trust, a lot of confidence that he was doing the right thing, because I could see the impressive button and her body just moving and her tongue getting numb, her face pulled to the side, all that kind of stuff.
It sounds like there may be some more things that can be done.
Yes, that's what we were working on.
It's 2:52. This is supposed to stop at 2:50.
250, yes.
Does anybody have a last burning question?
I do.
Yes.
My son was diagnosed when he was 16 years old. So now he's
With what?
he was diagnosed at 16 years old and put on medication. So at 23, he's still suffering. So we both talked about reevaluation. What does that look like?
Has he been seen at an epilepsy center?
He had some complications with Netflix and I didn't share it out loud, but we had some issues, and so now we're at Mayo in Rochester, Minnesota. And so we're working here, but I'm
These are the psychosocial, what we call comorbidities that epilepsy centers deal with. The problem with a center like the Mayo Clinic, which is an excellent center, is that they draw patients from all over the world, people who don't live there. And so they go and they get evaluated and then they leave. But if you go to an epilepsy center near where you live, where you can keep going back, you can get involved in programs that help with the psychiatric comorbidities. Depression is a common complication of epilepsy.
So what about the reevaluation? Is that going to be, is that sort of, is that again, baseline again? Do they start?
Yeah, so I would start again in another center. But one of the things we didn't talk about is the mortality of seizures. And I'm sure you all know about suer, sudden unexpected death in epilepsy, patients die from status epilepticus. But one of the things that's not realized is that one common cause of death in people with epilepsy is suicide, because depression is such a common complication. And it's not just that they're sad because they're sick. There's something about the chemistry of the brain with seizures that causes depression that requires specific treatment. And epilepsy centers are specialized in doing that. Okay? Thank you very much.
Just one more. Thank you.
Oh, good.